Hey guys, happy Friday. What's going on? Happy Friday. My YouTubers, welcome in. My Instagrammers, happy Friday. Good to see everybody again, waving back at everybody. So for anybody that's not been on here and anybody that's just jumping on, feel free to ask any sort of performance, fitness, anything you got related to that. I'm happy to answer anything you have. So, we'll talk a lot about overhead squat, what that's different ways to progress and different movements and things that you might see and use on a regular basis. So, guys, feel free, give me a shout, give me some stuff to work on. My like I said, my YouTubers. This is our new endeavor here, so let's see how that goes. And my Instagrammers. Let's get into it. So, exercises to help the ankle joint. So the ankle joint obviously is, when you injure it, you have whatever you did to it. Certainly can be a restricting issue there. And when we look at lower body, from squatting to lunges to all those fun things that people like to do, that ankle ends up creating some significant issues there. We'll call it lower leg or lower extremity dysfunction. Some things to check out, some things to kind of take note of. Number one, you have a propensity, and again, depends on the injury, it depends on what you did, but you have a propensity for that gastroc, the fibularis muscles, to be, particularly lateral head of the gastroc and the fibularis muscles, to be overactive or to have this kind of hypertonic state to it. So release those, release the gastroc, release the fibularis muscles if you feel comfortable and if you are able. That ankle joint or that ankle self-administered mobilization, again, find it on the website, but that ankle mobilization works wonders for people. It's just a simple resistance band. You're set up so that foot's on a chair, on a step or whatever, that band's pulling down and behind you, and you go into some like quick oscillations. It works wonders for, clearing up some of that restriction at that ankle joint. From there, you can maybe do some stretches for that calf, maybe that like slant board calf stretch or modified calf stretch, depending on what you have. And then some tibialis anterior activation, right? I think that's kind of our, or at least my go-to when we have that ankle restriction. So, hopefully that's somewhat helpful. Again, there's a lot, I don't know exactly what you mean after snapping it. There's a lot of things that could have happened there. But that's kind of what we see in general, right? But if you have something a little bit more specific to you, then check that out. All right, so hopefully that's helpful. Let's see. Manny asked, how do you fix rounded shoulders? So that again is a very common sign of dysfunction that we see as well. That upper body dysfunction, very common. To see that, especially now in this digital age where everybody's kind of zooming or on their computer for long periods of time. So the solution there for that rounded shoulders, again, we have this common musculature that has this overactive behavior to it. We see lats really contributing to the internal rotation of that humerus. So that like kind of internally rotated position there. Lats are going to be that main driver. So do some releasing of the latissimus dorsi. Also, we have pec minor, you have rhomboids, and you have levator that can all contribute to movement of that scapula. So, and particularly that movement of the scapula of like anteriorly tipping and kind of setting it down into that downward rotation, which creates that forward shouldered position. So it kind of gave you that solution there. Release rhomboids, release levator, release pec minor, release lats, right? And then you can do some stretches. You can do, whatever kind of stretch mobility piece that you wanted to do there for those muscles. I like child's pose. I tend not to stretch the neck a whole lot, but that child's pose works pretty well there. And then activation. Activate those commonly underactive muscles of low trap, You have that mid-trap combo is a good one, and then serratus. Don't forget serratus anterior, right? So I think that one may actually have a little bit more control on that scapula. I know you had said when scapula kind of, or that the shoulder blades kind of pop out, but that serratus anterior is a key component to all of that. But you have to make sure that you release the overactive stuff first. You can't just do serratus activation and think that's good enough. Do the release techniques first. Do some of the joint mobilizations if you feel comfortable with them, and then jump into those activations. From YouTube, what's going on, Patrick? Does the overhead squat show signs of hypermobility dysfunction? Sometimes, and again, it depends on what you're looking for. So when you have somebody who does that, is set up in that overhead squat, and you have them kind of stand up, you may be able to see some of that knee, that excessive knee extension when they stand up. That might be a red flag for you. As they bring their arms up with that overhead squat, you actually may take a good look at that elbow, and you may find that elbow kind of like bends backwards for somebody who's hypermobile. Also, as they stand up or as they're doing that movement, you may find too much range in that spine. The overhead squat's not a great assessment for spine, so maybe there's some other things that you might want to check out for that. But I think for somebody who is hypermobile, you will see some of those signs in that overhead squat, and that's something that you have to internalize too and go, all right, so if they're hypermobile at the knee, we don't need joint mobilizations and we don't need necessarily more stretching. We need more stability and control. So their kind of best bet would be to focus more so on like a stability endurance based protocol, like a program of some sort, and certainly incorporate some of those activations where they can control that a little bit better. And so at some of those joints like the knee and the elbow, even at the shoulder, if they can get their shoulder kind of way, way back, then maybe that's a pretty good a sign of hypermobility. The spine, not so much, but you might be able to pick some of that stuff out. So hopefully that's helpful. Glad to see you're on YouTube. So what's up, Heather? Hope all is well. You said hello. Happy Friday to you guys. What else you guys got? Ankles and running. So again, ankles, they are a problem area for a lot of people. I think kind of that same kind of setup, that same treatment or intervention plan. Release gastra, common overactive muscle. Release fibularis muscles, common overactive. And then also when you're doing your activations there, we want to make sure we take out those common overactive synergists. So when we do our tibialis anterior work, a lot of times what you find, if you can pretend this is my foot here, a lot of times what you find is like the big toe or the other toes kind of lead that dorsiflexion. Like that's the first thing that happens. That's a pretty good indicator that you have some overactive synergists work in there. Those extensor muscles, the extensor of the toe muscles, extensor hallucis longus and extensor digitorum longus. So we got to find a way to do an activation for tibialis anterior that takes those guys out of the game, right? So there are some ways that you can do that. If you've seen some of the videos on the website, we'll kind of show you how to do that to prevent some of those overactive synergists from kicking in. But obviously with running, sprinting, my field athletes, my court athletes, all those individuals that are really kind of doing kind of a running based or sprinting based activity, you get a lot of overactivity in there. So you address it as best as you can. And all you're looking to do is position that person in the best possible position for them to go and compete and do whatever it is that they're going to do. So you're not necessarily going to, let's say you have an athlete who's got flat feet. You're not going to fix that flat foot in one session or maybe even 10 sessions or 50 sessions. So it might be one of those things that you have to continuously work on. But as long as you do those corrective exercise interventions prior to them getting on the field, getting on the court, getting into their training, doing those runs, you've positioned them in a better position to enhance their performance and prevent significant or potentially prevent some significant injury or discomfort or something along those lines. So hopefully that's helpful. Evans Sport Massage. I would definitely say, since you're a massage therapist, I'm assuming, certainly work on that lateral gastroc and fibularis muscles, and see if you can do some activation in there at tibialis anterior if that's within your scope. So cool. Hopefully that's a lot of ankle stuff. And again, like I said, the ankle is a big restrictor of motion, right? Especially in squatting, right? If you don't have optimal dorsiflexion, your squat is not going to go very well. So, it's a great question, and something that we all probably have to work a little bit more on for the most part is that ankle mobility side of things, right? And it's not just, doesn't just mean, when I say mobility, it doesn't just mean stretching, right? That's not always the case. Let's see. Is it possible to compensate for hypermobility? Sure. One of the things that I find with my hypermobile individuals, a couple things really. So they're always complaining or asking or talking about being tight or stiff, and they're not, right? So they don't need more stretching, right? That's one thing I get all the time. Those hypermobile individuals constantly feel the need to stretch or whatever, and that's just a neurological thing, and that's not something we really need to do. So my hypermobile individuals, I don't really do a lot of the stretches with, because that's not what they need. Maybe we can do some releases, but I stay away from the stretches for those hypermobile joints. Now, the other thing that I find with some of the hypermobility individuals is that they tend to compensate, and they compensate really, really well. Whether that's not necessarily antagonist muscle development, but just in general, lots of compensation, because there's so much, let's call it, laxity in those joints. So, for example, a simple like a curl, there's a lot of kind of movement at the scapula as that person does that curl, because there isn't that much stability, because they're more hypermobile. So that's where we really have to kind of dial into, when our programming, incorporate those tempos. And I think that's one piece that's really missing in a lot of the hypermobile individuals' routines, is to focus on tempos with their resistance training. So like a 3-second eccentric, 2-second isometric, a 1 or 2 second concentric. So they're forced to control through that full range of motion, right? Versus just saying, okay, do 10 reps, and you see them just kind of like do 10 reps. That's probably not the best thing for them. So I would focus a lot on that tempo, that 3-2-1 or 3-2 whatever 2-2 tempo, kind of a controlled concentric tempo would be the way to go, right? But I tend to use the 3-2-1 tempo for that, and I stay in there. I stay in that tempo range, or stay in that phase, that stability endurance phase with them for about a month or so. I may progress to the hypertrophy or general strength phase, but I'm still using tempos. I'm still doing a 2-0-2 tempo. So it's 2 seconds eccentric, 2 second concentric. So they're still forced to control. And then I'll go and revisit, for my hypermobile individuals, I go and revisit that stability endurance phase, quite a bit. So that's kind of my advice for you, and kind of go from there. Piriformis Syndrome. There's a lot to that, right? So do your assessment, right? Do that overhead squat. Identify the signs that you see. So do you see knees bow out? Do you see asymmetrical weight shift? Do you see feet turnout? Do you see, whatever excessive, whatever dysfunction you see? Treat the signs. Don't treat the symptom, like Piriformis Syndrome. It's not always as simple as, well, just release piriformis and move on, right? It's not always that simple. You might have to address, or you should address the sign of dysfunction that you see in their assessment, right? I think I find a lot more success with, or better outcomes with, going, okay, this person may have that discomfort that's similar to Piriformis Syndrome, right? But they had an asymmetrical weight shift or a knee bow out sign or something along those lines, and we're just addressing those muscles that would be relative to that, making sure we're releasing, doing the mobility work for the overactive muscles, the activations for the underactive muscles, and go from there, right? So I think that's your best bet. That's kind of where I would go with that one. Treat the signs of dysfunction, not the symptoms. Let's see. Somebody with knees turn in. I'm assuming you're saying knees bow in, right, where the knees kind of come together. Let's see. So it might not be a lateral gastroc side of things. So when you see knees bow in, knees bow out, the asymmetrical weight shift, they can come from even excessive forward lean. They can come from either the ankle complex or they can come from lumbopelvic hip. So what my suggestion would be is to do that assessment, see what you find on the regular overhead squat, take note, and then do that overhead squat with modification. Elevate the heels, put the hands on the hips, and have them squat again and see what's still there, right? Because if all of those signs that you saw in the initial squat went away, then you know it's coming from either the ankle or the shoulder. Really, it's the anterior pelvic tilt. If the anterior pelvic tilt goes away with the hands on the hips, then you know the anterior pelvic tilt's coming from the lats. But talking about your knee bow-ins individual, if you do that overhead squat, you see knee bow-in, elevate the heels and knee bow-in goes away, well, then we know it's coming from the ankle. It's a restriction at the ankle. But if knee bow-in is still there with their heels elevated, then that knee bow-in is coming from the lumbopelvic hip complex. So it's a whole different set of muscles that we would have to work on for that individual, right? Compared to the person who, had the knee bow-in go away versus the person who had knee bow-in not go away with the heels elevated. So that kind of would be my suggestion. Make sure you can kind of differentiate where those signs or where those compensations or restrictions are coming from. How to address lack of tibial internal rotation inhibiting squatting depth? Probably wouldn't do that one. I would more so focus on goniometry of the ankle. I think that would be a more accurate sign there for you. So I would test, that goniometer is really going to be your best bet as a secondary assessment tool, something that helps to just kind of confirm what you saw in that overhead squat. So what I would say is put them on that table, bust out that goniometer. If you're not comfortable or familiar with it, we have videos on how to use that. Measure that dorsiflexion from on one ankle and measure it on the other. Make sure they're somewhat symmetrical, or maybe if they're asymmetrical, you have another list of things that you can do. But that dorsiflexion, they should have somewhere around 20 degrees of dorsiflexion, and that's going to give you a better, I think, a better indicator of what might be inhibiting your squatting depth, right? So if it's coming from the ankle. Let's see, my elbow almost locked tells about that. I'm assuming, I'm sorry. I don't elbow lock mobilizations. So there is an elbow mobilization that you can do if you have somebody who's got hypo mobility at the elbow. But if you're somebody who's got hypermobility, you don't need to do mobilization. So hopefully that makes sense. Let's see. So limited hip range of motion with hip internal rotation, but hypermobile external rotation. Could it rule out some TFL shortness? Potentially, sure. But it might not rule out TFL overactivity. So maybe it's not necessarily, the shortness or kind of, I don't know, whatever you want to call it there, that shortness of TFL. There may be some other things coming from that, right? So there may be some other muscles that are associated with whatever issue that you might be having at lumbopelvic hip complex dysfunction. But yeah, we can go, okay, well, maybe I don't need to stretch the TFL, but maybe I do need to do some release techniques. Maybe I need to do some release and lengthening techniques of some other muscles. Again, go back to those signs, right? Go back to your overhead squat, see what you find, what's going on. Is it an anterior pelvic tilt? Is it knee bow out? Is it knee bow in? Is it an asymmetrical shift? Is it excessive forward lean? So go back to those signs, bust out the, let's call it, do the math of putting the muscles together that would contribute to that specific dysfunction, and then see what you come up with, right? And then you can use that goniometer to go, okay, this muscle was tested to, or this joint was optimal range of motion. This joint had restricted range of motion. Okay, let's do the math there. What muscles or what tissues could be associated with that? And then kind of plug and play and put something together for you there. I wish it was super simple and easy that I could just kind of give you the answer there, but you'd obviously have to do that assessment on that person, right? Let's see. Oh, good question. Obstacle course is that one's tough, right? So what's the best training split to train for an obstacle course race? It really depends on where you're starting from. If you're somebody who's seasoned and trained, then my best advice would probably to stick to more of like an endurance-based training program. Certainly, there's some hypertrophy that would maybe benefit you, but again, depending on how much time you have before the race, like there's that whole kind of continuum of the in season and out of season and when the race or competition is. So there's a lot of variables there, but for the most part, I would say if you are kind of just starting out, certainly do some of that endurance stability, maybe go into some hypertrophy or general strength, and just kind of teeter back and forth between those two phases. Maybe once a month or so, do transition to that phase or back. I would probably stick to, and again, the training split is very dependent upon the training age of the person. So if you're somebody who's been working out for years and years and years, maybe you can do a little bit of, a total body for 3 days or maybe even 4 days out of the week if you can recover from that. If you're somebody who's fairly new, maybe total body 2 days a week, and then a couple other, maybe an upper body focus one day, a lower body focus another day, total body on the third day. That's kind of like I need more info to give you the best option there. And again, if you're kind of like a week out from that competition, you may actually want to tone back on that training and focus a lot on some of that corrective exercise stuff just to prepare you for that race. So there's a lot of pieces in there, but I would say the primary focus would be stability endurance. That would be my focal phase, if you want to call it that. And this training splits, if you're going to go 3 days a week, I'd probably go total body. Right? Total body 3 days a week, and go from there. I probably wouldn't do like chest on Monday, back on Tuesday, legs on. I wouldn't do that type of split routine. Candace, I'm glad that helped. Let's see. Feet turnout. Will it be helpful to encourage toes pointing forward and walking during the day? Again, that's a tough one too. It's a tricky sign to correct, especially if somebody's like falling into that feet turnout throughout the day, throughout their work, throughout whatever they're doing. One of the things that kind of that can kind of help with that is the taping. So if you're familiar with the kinesio taping, I would say, hey, you know what? Throw some kinesio taping on there, and all that's going to do is not going to fix the problem. It's just going to give them that subtle reminder of, hey, you know what? When your foot starts to turn out a little bit, you get a little bit of that stretch or that pull on that tape. So it just kind of gives a little bit of like I'd say like your grandparent kind of like flicking you in the ear when you're not sitting up straight kind of mentality. So that little bit of tension or stretch on that tape may just give them a little bit of a reminder to like, oh, I gotta straighten my feet up, right? So maybe that's a solution. The other solution that I would say, and really this goes for any sort of dysfunction, is to make sure that you're giving that client or patient some stuff to do on their own throughout the day, 1 to 2 times a day if they can. That's going to help with that dysfunction that you're trying to address. So if you have somebody who's got feet turnout, feet turnout is primarily coming from overactive bicep fem, potentially lateral gastroc, could be driven by a lack of dorsiflexion. So some quick things that you can do for them is to give them a tennis ball or a softball or just something that they can have and say, hey, do your bicep femoris release, do your lateral gastroc release, and then do a calf stretch throughout the day, right? Like 2 times a day as you're doing nothing, as you're standing, waiting for copies to print, do a calf stretch or something like that, right? So that would be my best with that. Candace, can you explain the difference between squatting with toes pointing forward versus toes, knees externally rotated with the hips too? Is there one better for specific population purpose and limitations? You should squat with your feet pointed straight, knees in line with the second toe, toes pointed straight, feet underneath that ASIS, that anterior superior iliac spine. As you squat, your tibia and torso should remain parallel to one another. That would be ideal. That is going to provide you the best absence of dysfunction, absence of compensation, which will position you to be in the best position you can be in to prevent injury and pain and discomfort and things like that. Now, when you start seeing all those other squatters out there and their feet are real wide and their toes are out to the side and all of those things, unfortunately, a lot of that was taken from kind of that powerlifting community. And there's not to knock it, they do that because as you go feet wide, you shorten the distance that you have to travel, which enables you to potentially lift more. And by not traveling or not having to travel so far, right, you don't have to move as much or move as much weight as far. So they utilize that wide stance in their deadlifts or in their squats to kind of minimize that distance. And even a small distance makes a huge difference. Now, there's inherent risks with all of those different positions. So feet wide, toes turned out, like there's different risks that are associated with that. There's different positionings that can cause issues from the lumbopelvic hip to the sacroiliac joint to the knee joint to the ankles. So, but for powerlifters, that's part of the sport. That inherent risk is part of the game. So you accept that and you just lift as heavy as you can. Fair enough, but that doesn't mean that position is ideal for the majority of the population to be or get stronger. Like that doesn't always correlate, right? So I would suggest, right, doing your release techniques that you find appropriate, your joint mobilizations that you feel comfortable with, the lengthening techniques that you feel are appropriate, the activations that you think are necessary, and then when you have somebody squat or lunge or whatever, feet underneath the ASIS, second toe straight, have them go down to the lowest spot that they can go without discomfort, without pain, without whatever. It doesn't have to be to 90. It doesn't have to be all the way to the ground. You go to the lowest point that you can without discomfort, without pain, without compensation. So hopefully that's helpful. That works. If you guys have more questions, I'll be back on next Friday. My YouTubers, thank you for jumping in. It's our first time on YouTube, so welcome on in. And guys, I got to get going. So happy Friday. Have a great weekend. Go do great things. Go be awesome. Great questions as always. Appreciate you all. And I'll see you guys next week. If I missed your question, it's not. I'm sorry. But I'll see you guys later. Bye, everybody. If you're having significant issues or pain, go see somebody. That's my answer. See you guys.